Next speaker, Dr. Abhijit. Can vitreous be the cause of unexplained visual loss? Dr. Abhijit.
Yeah, thanks, Dr. Nagendra Prasad sir, for giving me the opportunity to talk in this esteemed podium. So, my topic is: Can vitreous be a cause to unexplained vision loss? So, if we see vitreous in a clear media, maybe creating a problem, which we can see in the diagram, that in the visual axis that may create problem which can cause unexplained vision loss. Along with that, the vitreoretinal interface disorders are there which can create problem also. So we'll try to keep it simple. So common causes for vitreous causing the problems are posterior vitreous detachment, vitreous hemorrhage, intermediate uveitis, and vitreomacular traction and vitreopapillary traction. So posterior vitreous detachment, we get separated posterior vitreous or the Weiss ring in visual axis associated with floaters and flashes. Sometimes we may get retinal breaks, and there may be associated vitreous hemorrhage or even retinal detachment. So this one is the Weiss ring we can see usually resolves spontaneously, but sometimes may need subtotal vitrectomy. Then this is a very common entity which we miss very regularly, the intermediate uveitis. We get patients even the for few years they are having slowly decreasing vision and they don't get much problem, maybe sometimes topical steroids. So this is intraocular inflammation mainly focused on vitreous and peripheral retina as per the definition of standardization of uveitis nomenclature, predominantly painless, floaters, and vision decreasing. There will be cells in vitreous, very mild to moderate AC reaction, snowball opacities, snow banking, and peripheral retinal phlebitis we may get. So this is one of the photos we get in the wide angle photo. The treatment is mainstay corticosteroids. This is a stepwise, ladder-wise treatment we tell. And then if it is not responding, then we go to the immunosuppressives, then cryotherapy and laser to the peripheral lesions, and of course, pars plana vitrectomy. Then there is vitreopapillary traction. This entity is also very much ignored, in fact, because we may find even disc edema also unexplained. We may advise the patient to undergo MRI and a PEP. But if we do an OCT, we can get it there. In case of decreased vision, we have to go for pars plana vitrectomy. Then there is a vitreoretinal interface disorders that encompasses 3-4 entities like vitreomacular adhesion. They have the grades 1, 2, 3. Then the vitreomacular traction, distorting the fovea, then macular hole, and then macular edema with posterior hilar traction. So how it decreases the vision? There are few of the entities like epiretinal membrane, cystoid macular edema, and pseudocyst, macular schisis, and subretinal fluid, the final common pathway. So imaging we do of the vitreomacular interface with the slit lamp biomicroscopy clinically, then ultrasound, and of course OCT. Treatment protocol for the vitreomacular traction is, or vitreomacular interface disease, is observation mostly, because spontaneously it releases, the traction releases in 30% of cases in grade 1 and 2. And then the surgical removal. Nowadays we are doing this pharmacologic vitreolysis for focal type of lesions with ochriplasmin. There are a few other enzymes also which has been used, and papers are there. So there are a few of the surgeries, very small clips. So before surgery, you can see the bad epiretinal membrane is there with the vitreal, the foveal contour flattened. And here, if we see, this is a 27 gauge surgery, and we can see the bad epiretinal membrane. And this is with the forceps, we peeled it off, and wherever we can get the hold, we peeled it off, and you can see over the posterior pole, crossed it, there is some vitreopapillar adhesion also that we have to take care. And this is an old case of blood retinal vein obstruction with laser in the periphery. You can see those areas. And there is another one you can see here. This is also 27 gauge. And this is the same case, I think. This is a 25 gauge vitrectomy, and You can see a bad membrane in the posterior pole. So after doing vitrectomy, we put triamcinolone, and then you can see the triamcinolone attached over the epithelial membrane. We stained with the billion blue dye also. So after the ERM peeling, we did the ILM peeling, and at the end you can see we stained twice with the brilliant blue to confirm that ILM also peeled here. Basically, peeling the ILM prevents ERM from formation. The recurrence rate is much less. And there is another 27 gauge surgery after the tricot assisted PVD induction. We can see there is a epiretinal membrane with macular hole here. So here we peeled it, and is the inverse flap technique, that is the stained with the brilliant blue dye, and with the phenycyl loop we just took the membranes and put it over the macular hole, closing it, and we did the fluid exchange in the normal way. So this is the before and after surgery we can see. So this is the acknowledgement, few slides we took from Dr. Rajesh, and my colleagues Dr. Jonaki and Dr. Shubhankar also helped me us. So thank you, and this is one request to all to attend our AIOC conference 2024 in Calcutta. Thank you.